this is Dr. Ajay Kare, Assistant Professor at UNMICRC Hospital. I am presenting today topic Atrial Septal Defectecho Assessment and Management. Going to the history, Botello described the patent foramen oval. Leonardo da Vinci account of a true atrial septal defect is thought to be the first record of congenital malformation of human heart. Carl von Rokitansky in 1875 distinguished septum primum from septum secundum defects. In 1921, Ashman's description of the radiology feature of atrial septal defects is noted. To the incidence, ASD 8 to 10% accounts for the congenital heart disease in children, 20 to 40% of the congenital heart disease in the adults. Out of this, ostium secundum atrial septal defect accounts for the 75%, ostium primum of ASD accounts for the 15 to 20%, sinus venosus ASD accounts for 2 to 10%, coronary sinus atrial septal defect account for less than 1%, which is associated with other syndromes, heterotaxis syndromes. There are some genes and genetic disorders associated with the atrial septal defects. Genes comprise NKX2.5 CSX. There are transcription factors TBX5, GATA4, GATA6. The syndromes associated, genetic syndromes associated with the ostium atrial septal defects. These are Holt-Oram syndrome, which is associated with ostium secundum atrial septal defect, upper limb abnormalities and AV conduction delay. Noonan syndrome, Down syndrome, Klinefelter syndrome, Williams syndrome, Ellis-Van-Creveld associated with ostium secundum ASD. There are maternal and environmental factors which contributes to the development of the ostium secundum ASD. Gestational diabetic mellitus, phenylketonuria, maternal influenza, infection during the gestation period, the exposure to the retinoid, NSAIDs, anticonvulsants, thalidomide, smoking, alcohol, all can contribute to the ostium secundum ASD, atrial septal defects. Embryology of the atrial septal defect. At the age of 29 days of the gestation period, septum primum start develop, and at 33 days septum primum starts fusing to the AV cushion, which leads to the ostium primum there. At 37 days the ostium secundum is formed, and the complete ASD, complete atrial septum is formed by the 55 days with the there is a slight defect called foramen oval at present. The atrial septum has three components: septum primum, septum secundum, atrioventricular canal septum. The sinus venosus is not a component of the true atrial septum. Septum defects can be classified according to their anatomic locations in the intraatrial septum. First is the ostium secundum ASD, which occurs at central intraatrial septum due to true deficiency of the septum primum, can occur rarely due to deficient growth of septum secundum. Ostium secundum ASDs can enlarge over time with age and cardiac growth. Second is ostium primum ASD, which is also associated with the partial AVCD, AV canal defect, seen in the inferior intraatrial septum as a part of spectrum of AV canal defects. Common AV valve annulus and two AV valve orifice. Both AV valve in same line is seen. Two bridging leaflets instead of AML, intermitral leaflet and septal tricuspid leaflet that straddle from the right ventricle to the left ventricle, which is it is also associated with the left mitral valve, cleft left mitral valve. Sinus venosus ASD, ectopic or incomplete incorporation of right horn of sinus venosus. Deficiency of valve that separates right upper pulmonary vein from SVC, which is called SVC type. Deficiency of valve that separate right lower pulmonary vein and right middle pulmonary vein and the RA, which is also called the IVC type. 90 to 95% associated with the partial anomalous pulmonary venous drainage. IVC type of sinus venosus ASDs are very rare. Coronary sinus atrial septal defect, which are the rarest form of atrial septal defect, which are due to the left horn of sinus venosus, which is involved. This is also called the Raghib syndrome, which is comprised of the coronary sinus atrial septal defect with the left-sided SVC, supravenous cava. A shunt will be from the left atrium to the dilated CS to the RA. Failure of development of wall between the coronary sinus and the left atrium is the cause. There are types of coronary sinus. Type 1 complete unroofed coronary sinus with LSVC. Type 2 is complete unroofed coronary sinus without LSVC. Type 3 is unroofed at mid portion of coronary sinus. Type 4 is unroofed at terminal portion. There are different entities with the intra-atrial septum. These are the atrial septal aneurysm. It is a rudimentary or saccular deformity of the atrial septum, which is defined as excursion of septal tissue of greater than 10 mm from the plane of the atrial septum into the RA or LA. A combined total excursion right and left of 15 mm is also called as septal aneurysm. The prevalence of atrial septal aneurysm is 2 to 3%, which is associated with PFO also. There is, in certain situations, there is increased prevalence of cryptogenic stroke and other embolic events. Eustachian wall is a remnant of the wall of the IVC. A large Eustachian wall with PFO can cause the paradoxical embolism. The Eustachian wall extends anterior from the IVC to the RA junction. Another entity is Chiari network, remnant of the right wall of the sinus venosus, filamentous structure in the various places in the right atrium. Chiari network, 2% to 3% of population is the occurrence. It is also associated with the PFO and atrial septal aneurysm and can lead to the embolic phenomena. This diagrammatic representation can show the location of the various atrial septal defects. Above we can see the sinus venosus atrial septal defect, which is SVC type. Second, ostium secundum ASD, ostium primum ASD, sinus venosus ASD of IVC type, and unroofed coronary sinus. Atrial septal defect association. ASD is very important in certain congenital disease for survival, like hypoplastic left heart syndrome, transposition of great arteries, tricuspid atresia, and TA-PVC. The atrial septal defect is very important in certain situations for the survival. Partial AVCD, which is associated with ostium primum AVCD, partial anomalous pulmonary venous circulation in 90 to 95% of sinus venosus ASD, pulmonary stenosis, left supravena cava in coronary sinus ASD, non-compaction of ventricle. ASD and pregnancy. Patient is usually diagnosed during the late childhood and early reproductive age group. ASD is well tolerated during pregnancy, even no complication during multiple pregnancy. Brisk hemorrhage during delivery provokes a rise in systemic vascular resistance and a fall in systemic venous return, a combination that augments to the left to right shunt. There is a risk of peripartum paradoxical emboli. The natural history of atrial septal defect. The mean age of death is approximately 37.5 plus or minus 5 years. 75% of die by 50 years. 90% of patients with ASD die by 60 years. Less than 5 mm ASD in infants spontaneously closes. ASD more than 8 to 10 mm unlikely to closes. ASD more than 10 mm size can increase in size, noted in 65%. Pulmonary hypertension, right to left shunt, atrial arrhythmias, right ventricular failure can occur over the age progresses. Eisenmengerization in certain situations occurs in late in ASD, occurs earlier in VSD and PDA. The clinical features of atrial septal defect. Most common is dyspnea and fatigue is the most common symptom. Second, other is orthopnea, then recurrent lower tract infections in children. Older patient deteriorate chiefly due to 3 reasons: decreased LV distensibility, increased prevalence of tachyarrhythmias, and pulmonary hypertension. Physical findings: arterial pulse is normal even though left ventricular ejection fraction tends to be decreased. JVP, the most important is left atrialization of the jugular venous waveform. The crests of the A and V waves tend to be equal, and pulmonary vascular disease lead to giant A wave. On inspection and palpation, precordial movement and palpation, right ventricular impulse is hyperdynamic. The impulse is especially prominent at the left sternal border during held exhalation and in the xiphoid area during held inspiration. Palpable P2 in left second intercostal space is noted. Systolic thrill can be present in pulmonary area. On auscultation, wide fixed splitting of S2 is hallmark. The S1 split is present and tricuspid component of the S1 is loud. Mid diastolic rumble present in the tricuspid area. Pulmonary mid systolic murmur, presence of crescendo decrescent type, best heard in pulmonary area. Loud P2 is also present. On ECG, there we can get the sinus node dysfunction, which has been identified as early as 2 to 3 years of the age. The incidence of AFib, atrial flutter and SVT increases in the 4th decade. Atrioventricular conduction defects are common in ASD but less common in the SA dysfunction. Advanced first degree atrioventricular nodal block occurs with familial or less commonly non-familial atrial septal defect. Other findings are tall and peak P waves present. The P wave axis with an ostium secundum ASD is inferior, and to the left with upright P waves in lead 2, 3 and AVF. With SVC type of venous atrial septal defect, P waves are inverted in lead 2, 3 and AVF and upright in AVL. These are the differentiating points between the ostium secundum ASD and the venosus type of atrial septum ASD ECG wise. Right axis deviation arrives secondary to the pulmonary arterial hypertension. Left axis deviation determines ostium primum ASD and left fascicular block. So, in ostium primum ASD, we will be able to get the left axis deviation. An electrocardiographic hallmark of ASD is an RSR pattern or an RSR prime in right precordial lead. A notch near the apex of the R wave in inferior leads of ostium secundum and sinus venosus ASD has been called the crocodile sign. As we are able to see this in ECG leads, there is a notch in the R waves near the apex of the R waves in the inferior leads 2, 3 and AVF, which is the crocodile sign. ECG of ASD primum showing a left axis deviation, incomplete RBB with QRS in V5 and V6. ECG in sinus venous ASD showing a rightward axis, RSR in V1 and inverted P in lead 3. So, if the P waves would have been positive in this 2, 3 AVF, it would have been ostium secundum ASD with right axis deviation. In chest X-ray, there will be increased pulmonary arterial vascularity. The pulmonary trunk and its proximal branches are dilated. The sinus venosus atrial septal defect may be accompanied by localized ampullary dilatation of the superior vena cava proximal to its attachment to the right atrium. There will be RA and RV enlargement. Other very rare finding can be the jug handle type of cardiac siloth, inverted comma shaped appearance. The very much important in atrial septal defect is the echocardiographic evaluation. The various points need to be emphasized in echocardiographies. The very much important is the detection of atrial septal defect. This quantification of the size and shape, the rims of tissue surrounding the defect, the degree and detection of the shunting, associated cardiac anomalies, remodeling and changes in size and function of the cardiac chambers, pulmonary circulation, aids in device closure, detection of post-procedure complications. ASD rims are very important in determining the device management or surgical management. The first is aortic rim, superior anterior rim, as we are able to see this aortic rim. Second is AV wall rim, inferior anterior rim. Here we are able to see the inferior anterior rim. The SVC rim, superior posterior rim. IVC rim, inferior posterior rim and posterior rim. Right upper pulmonary vein rim, part of posterior superior vein. So, at the SVC we are able to see the superior posterior rim, At IVC we are able to see the inferior posterior rim, and P which signifies is the posterior rim. Indirect echo evidence when we should suspect on echocardiography that there can be the possibility of atrial septal defect. If we get the right atrium and right ventricular dilatation in apical 4-chamber view, we should look for the types of atrial septal defect. If we are able to find the intraatrial septum dropout in apical 4-chamber view, abnormal intraventricular septal movements, for example diastolic flattering and early systolic recovering of this flattening, and another index we can think of, we can suspect by estimating the relative atrial index. This RA area by LA area ratio of more than 0.92 as a 99% sensitivity for ASD detection. Direct views of ASD is possible. The various very important views for atrial septal detection in echocardiography. Subcostal views are very important. Subcostal coronal view, subcostal sagittal view, subcostal left antero oblique view, left parasternal axis short axis view, apical 5-chamber view, apical 4-chamber view, modified 4-chamber view, end-face view. Echocardiogram showing large atrial septal defect, ostium secundum type of atrial septal defect, as we are able to see RV, RA, ASD as a marker, LV. There is a large echo dropout in the mid portion of the atrial septum arrow in the 4-chamber view, and color flow seen from the left atrium to the right atrium in diastole. This is the 4-chamber view showing large defect in the lower part of the interatrial septum, which is a ostium primum type of ASD. Here we are able to see the sinus venosus type of ASD. Here right upper pulmonary vein SVC and the RA. There is a defect between this the double arrow we are able to see in the second image, which is a sinus venosus type of atrial septal defect. And previously I said the coronal subcostal view is very important, and this is the best view to look for the defect in atrial septal defect on echo eyes. The subcostal sagittal view, the probe marker is placed at 6 o'clock position from left to right tilt, profile the atrial septum from left posterior to the right anterior. The size of atrial septal defect can be assessed in craniocaudal axis. The posterior inferior rim, IVC rim, posterior superior rim, and coronary sinus rim sometime. The excellent window, this is the excellent window to image a sinus venosus type of ASD also. Subcostal sagittal view, here we are able to see the defect between the LA and RA. Apical 4-chamber view, which is not ideal for ostium secundum ASD as it is a far field parallel with the atrial septum. Echo dropout in fossa ovalis area also, which can give the false sensation of ASD. Can identify malalignment of septum in ostium primum ASD. It is used to assess the hemodynamic consequences of ASD, which is also useful in contrast echo, apical 4-chamber view. Left parasternal short axis view. IAS runs posteriorly from the non-coronary cusp of aortic valve, not seen entirely as a result of dropout artifact. Anterior superior rim can be profiled in this view. In this view, anterior superior rim can be profiled, posterior rim can be assessed, RVOT and MPA dilatation can also be appreciated. Apical 5-chamber view is the anterior aspect of the interatrial septum. Modified apical 4-chamber view is a halfway in between the apical 4-chamber and the parasternal short axis view, useful in those with poor subcostal window. Suprasternal short axis view, crab views, is very important by keeping the probe in the suprasternal area. Is help to identify all the pulmonary venous drainage. From this we can able to distinguish the whether various congenital disorder like total anomalous pulmonary venous connections or partial anomalous pulmonary venous connections. In-phase views of ASD on 2D transthoracic echo. There are two methods, 4-chamber view. First we have to get the best 4-chamber view, then rotate the probe by 40 to 60 degree counterclockwise, keeping the same position. Here we are able to, on the second image, we are able to see the end-phase view of continuous clear rim of defects. The role of color Doppler, continuous wave Doppler and pulse wave Doppler in assessment of ASD should be atrial septal defect. It should be as coaxial as possible. ASD flow pattern can be established, maximum left to right during the late diastole and the late systole. Transient right to left flow may be seen in rapid filling phase and early systole. Pulse wave spectral Doppler can be used for the detection of bidirectional shunting. The color scale setting should be adjusted to 25 to 40 cm per second to optimize for the expected low velocity of shunting. Contrast echocardiography is important in certain situation where the atrial septal defect can be the dilemma, like there will be IS dropout but there is no color flow between the dropout. So in that case we can do the contrast echocardiography also. For that, first we need to do the apical 4-chamber view, the best apical 4-chamber view. We have to prepare the agitated saline 5 to 7 ml, 5 ml saline plus 1 ml air. Contrast spill over to LA can occur even if flow is left to right Valsalva maneuver release during the Valsalva maneuver release phase. Bubble quantification grades: grade 1 up to 5 bubbles, grade 2 up to 25 bubbles, grade 3 more than 25 bubbles, grade 4 opacification of chamber, direct signs of left to right shunt, negative contrast effect, which is also called the ghosting. There will be certain area of in LA there that the bubbles could not be passed through that area due to the left to right shunt, which is called the ghosting. In pulmonary AV fistula, these bubbles will take 3 to 8 cardiac cycles for contrast spillover. False positive effect of negative contrast effect seen in IVC blood flow, coronary sinus flow, Jarbode defect, which is a not quantitative. Role of transesophageal echo in atrial septal defect, which is the most accurate, sensitive more than 100%. It is must prior to device closure in adults. The T should be done prior to device closure in adults. It can clearly identify the size, shape, number and defects in rims of ASD. Contrast study can be combined. AVCD can also be delineated. The basics for transesophageal echocardiography is: patient should be positioned in left lateral decubitus with topical lignocaine anesthesia. 4 to 6 hours of fasting and NPO at least 1 hour after T is mandatory. There should be the T probe should be introduced in unlocked position. We should avoid entry into the pyriform fossa. Clockwise rotation, probe turn to right and vice versa. Probe position relative to esophagus. The upper esophagus, mid esophagus, transgastric and deep transgastric. These are the probe positions. Upper esophagus is up to 20 to 30 cm, mid esophagus is up to 30 to 40 cm, transgastric is 40 to 45 cm, deep transgastric is 45 to 50 cm. Important views in atrial septal defect: transesophageal views. The upper esophageal short axis view, mid esophageal aortic wall short axis view, mid esophageal 4-chamber view, mid esophageal bicaval view, mid esophageal long axis view. The upper esophageal short axis view, the probe is kept at the upper esophagus at 0 degree, 50 degree, 30 degree and 45 degree. In this view, superior aspect of the atrial septum can be viewed. The roofs of the RA and LA can be viewed. SVC, ascending aorta, right upper pulmonary vein can be viewed. Help to see the SVC type of sinus venosus ASD and PA-PV, partial anomalous pulmonary venous connections. These are the upper esophageal short axis view. Mid esophageal aortic wall short axis view. at mid-esophageal position at 0 degree, 30 degree, 45 degree, 60 degree and 75 degree. This view facilitates anteroposterior diameter of ASD, aortic rim and posterior rims measured. The overlap of septum primum and septum secundum when the PFO is present can be appreciated. This is a mid-esophageal aortic wall short axis view. Here we are able to see the AO aorta, LA left atrium, RA is the right atrium, and the color jet we are able to see from the left atrium to right atrium, is depicted by the arrow. Mid-esophageal aortic wall short axis view. Here we are able to clearly delineate the defect between the left atrium, right atrium in the atrial septal. This is the ostium secundum type of ASD, with above one is the posterior rim and at the aortic side is the anterior rim. These are the atrial septal rim, eustachian wall we are able to see, and the aortic wall. Mid-esophageal 4-chamber view, 30 to 40 centimeter mid-esophagus position at 0 degree, 50 degree and 30 degree. This view is used to evaluate the atrioventricular septal AV septum deficient in primum ASD, the relationship of any ASD to the AV valves if planning large devices. Mid-esophageal 4-chamber view. Here we are able to delineate the defect. Mid-esophageal 4-chamber view, again we are able to see the defect which is depicted by the arrow. The defect causing the communication between the right atrium and the left atrium. Mid-esophageal bicaval V is also very important to delineate the SVC and IVC rim, which are best assessed in this view. The SVC and the right upper pulmonary vein can also be assessed. Sinus venosus type of ASD and partial anomalous pulmonary venous drainage can also be best delineated in mid-esophageal bicaval view. Eustachian wall is also well profiled. It is used to image the inferior and superior plane of the atrial septum. It is kept at the mid-esophageal region at 90 degree, 105 and 120 degree. Mid-esophageal bicaval view, we are able to see the SVC, IVC, the superior rim which is the SVC rim, inferior rim which is the IVC rim, left atrium RA, and there is a defect which. Next important thing is the hemodynamics in the atrial septal defect before going for any management. The primarily related to the direction and magnitude of shunting. Size of the defect is also important. The relative compliance of the right ventricle and the left ventricle is also important. The relative systemic and pulmonary vascular resistances. Compliance of right ventricle should be more than the left ventricle. Resistance of pulmonary vascular resistance should be less than the systemic vascular resistance. So usually the shunt should be left to right shunt to go for any management. So if in isolated atrial septal defect, QPQS should be calculated, which can be calculated as a PA, pulmonary arterial flow divided by aortic flow equal to pulmonary artery cross sectional area into pulmonary artery VTI divided by aortic cross sectional area into the aortic VTI. So closure is indicated if the QP by QS is more than 1.5 and the pulmonary vascular resistance is less than 5 Woods unit or less than 2/3 of systemic vascular resistance. RV volume overload is very important to estimate before going for any management. RV volume overload can be estimated as a D-shaped septum in diastole when the RV diameter is more than 41 mm at the base, when the RV diameter is more than 35 mm at the mid level, RV longitudinal dimension of more than 83 mm, RV volume index more than 87 ml per meter in males and 74 ml per meter square in females indicates RV volume overload. So RV to LV minor axis index more than 1, which says that it is a RV enlargement is present. Pulmonary artery hypertension is important. Pulmonary hypertension occurs earlier in sinus venous ASD than ostium secundum ASD. So PA pressure can be estimated by right ventricular systolic pressure, which is estimated through tricuspid regurgitation gradient plus right atrial pressure by echo-wise. If there is no pulmonary stenosis, diastolic PA pressure equal to PR gradient plus mean right atrial pressure. Mean PA pressure equal to peak PA velocity. Peak PA pressure less than 70% of systolic blood pressure is an indication for ASD device closure. In pediatric patient, ASD can produce peak pulmonary wall gradient up to 30 mm of mercury. More than 30 mm of mercury pulmonary wall gradient is associated with associated pulmonary stenosis. LV function is very important, especially in elderly before ASD closure. As the age increases, LVDP left ventricular end diastolic pressure is also increases, and there will be increase in the left to right shunting. If LVDP is high and ASD closure done, there is a risk of acute pulmonary edema to be occur and the patient may decompensate. Masking effect of the left ventricular end diastolic pressure measures due to the pressure equalization between the left heart and the right heart due to the ASD. Trial of occlusion of ASD and monitor of increase in the left atrial pressure can be done in such patient by balloon occlusion method. Stop flow method, balloon device sizing. Sizing balloon is passed through the ASD, inflated till no flow is detected with color Doppler, deflated and left to right shunt flow verified. Again inflated, keeping the balloon in the center of the IS interatrial septum. A waist may form and no flow confirmed by the color Doppler. This waist diameter is the maximum atrial septal defect diameter, which is useful to estimate the size of the device. Here we can see the balloon sizing, and we are able to see the, in second image we are able to see the vertical line which is a waist. So that is the diameter. So that is the diameter of the defect. We can estimate the size of the device that need to be used in such patients. Stop flow method is the hemodynamic effect can be studied also to the stop flow method. ASD device closure should not be done if mean pulmonary capillary wedge pressure increased more than 10 mm of mercury from the baseline value, or pulmonary capillary wedge pressure increased more than 20 mm of mercury in balloon test occlusion. So creation of fenestration hole on the device. So balloon occlusion test can be useful in situation to estimate the device of the size, to estimate the left to right shunt, and to estimate the pulmonary capillary wedge pressure which is increasing or decreasing. If it is increasing, then device closure should not be done. Importance of ASD rims. Less than 5 mm rim size is considered deficient. Adequate SVC, right upper pulmonary vein, IVC and AV wall rims are important for successful device closure of ASD. Aortic rim less than 5 mm is a potential risk factor for cardiac erosion. All measurements to be taken in ventricular end systole. In 2020 ESC European Society of Cardiology guidelines, in patient with shunt lesions, guidelines for shunt lesions, in patient with shunt lesions and non-invasive sign of pulmonary arterial pressure elevation, invasive measurement of pulmonary vascular resistance is mandatory. Adjusted recommendation for shunt closures when QP by QS is more than 1.5 according to calculated PVR. When there is less than 3 Woods unit of pulmonary vascular resistance, is a class 1 indication for closure for ASD, VSD and PDA for device closure, surgical closure. When there is pulmonary vascular resistance of 3 to 5 Woods unit, there is a class 2 indication for ASD, VSD and PDA. When there is a more than 5 Woods unit of pulmonary vascular resistance, but there is a decreasing to less than 5 Woods unit of pulmonary vascular resistance after targeted pulmonary arterial hypertension treatment, it is a class 2B indication for ASD with fenestrated closure only. More than 5 Woods unit for VSD and PDA. Careful individual decision in expert centers is to class 2B indication. More than 5 Woods unit despite targeted PA treatment, it's a class 3 indication for ASD and the ASD closure should be deferred. In patient with ASD and LV disease, it is recommended to perform balloon testing and carefully weigh the benefit of eliminating left to right shunting against the potential negative impact of ASD closure on outcome due to increase in filling pressures. Taking closure, fenestrated closure or no closure into consideration. Take older age into account in the decision for surgical ASD closure. In elderly patient not suitable for device closure, it is recommended to weigh the surgical risk against the potential benefit of ASD closure. So it's a flow chart diagram and schematic representation for the management of the atrial septal defect. Whenever you find the atrial septal defect, you need to assess for the right ventricular volume overload. So if it is present or not, if there is no right ventricular volume overload, you need to think for the suspicion of any paradoxical embolism. If there is no paradoxical embolism, there is no need of closure is required. If there is a suspicion of paradoxical embolism, you need to close the atrial septal defect, which is a class 2A indication. And if right ventricular volume overload is present, then you need to assess for the pulmonary arterial hypertension. The pulmonary vascular resistance of value of 3 Woods unit at least. And if it is pulmonary vascular resistance is less than 3 Woods unit, you need to take consideration of the LV disease. If there is no LV disease, it's a class 1 indication for the closure of the defect. If there is a LV disease, then you need to assess for the balloon testing. Balloon testing to assess whether it is required or not, to increase for the pulmonary capillary wedge pressure or not. If it is increased, so LV with the closure should be deferred. And it's also the benefit versus risk of closure also should be weighed in patient with ASD with pulmonary vascular resistance of less than 3 and LV disease. If we get the pulmonary vascular resistance of more than 3 Woods unit but less than 5 Woods unit and QP by QS of more than 1.5, then you can close this atrial septal defect, which is a class 2 indication. But if there is no, if the pulmonary vascular resistance is not less than the 5 Woods unit and QP by QS is also not more than 1.5, then balloon testing should be done before that. And if after that, after giving the anti-pulmonary arterial hypertension treatment, you need to look for whether pulmonary vascular resistance falls below 5 Woods unit after PS treatment, and QP by QS is more than 1.5. If yes, then go for the fenestrated closure, which is a class 2 indication. If no, then should not be touched these defects. Ideal age for ASD closure. In asymptomatic patients with large shunt, elective closure between 2 to 5 years of age is recommended. Symptomatic ASD in infancy with congestive heart failure, severe pulmonary arterial hypertension seen in about 8 to 10% of cases. Rule out other associated lesions like total anomalous pulmonary venous drainage, left ventricular inflow obstruction, aortopulmonary window. Early closure is recommended. Elective closure irrespective of age, as long as there is right heart volume overload and pulmonary vascular resistance is in operable range, which is a class 1 indication. Surgical closure, if there is a large ASDs, if defects are too large to allow direct suture closure, patch closure is performed. If there is a small to moderate ASDs with other associated conditions like TA, PVC, PAVC, direct suture closure of ASD is recommended. Contraindications for surgical closure are Isar-Minja syndrome and pulmonary vascular resistance of more than 8 Woods unit. Other surgical can be done is a concomitant MACE procedure if atrial arrhythmias in adult patients. Conventionally, medial sternotomy approach is the gold standard. More recently, partial lower sternotomy has been particularly used in children below 3 years of age. Long-term outcomes after repair depend on age at surgery and pulmonary artery pressure prior to surgery. Another method of treatment is device closure, which is first reported by the King et al. In 1976, Various devices are available. These are Atrial Septal Occluder, which is the commonest use. Other Cardiocil, Gore Helix, Septal Occluder, Clamshell Occluder, dash angle wings, and Biostar. Most common used is the Atrial device closure, as I previously said. It is implicated in septum, ostium secundum type of ASD closure. Atrial Septal Occluder, US FDA approved, which can be used up to defects up to 35 mm. Gore Helix Septal Occluder device defects up to can be used up to defects up to 17 to 18 mm. Helix device may be used in deficient anterior rim. We are able to see the second number Atrial device, how it looks, the Helix how it looks, and Cardiocil how it looks. The Atrial is a self-centering double disc device. The advantage of the Atrial septal occluder is easily withdrawable, frequently used, and easy to use. The disadvantage is the late cardiac erosion due to the device and allergy to the nickel. ASD device closure challenges. There are certain challenges while doing the device closure of atrial septal defect, which is a size more than 30 mm. Left upper pulmonary vein or right upper pulmonary techniques may be adopted. Balloon assist technique may be adopted. In elderly patient, pulmonary hypertension patient, RV dysfunction, and if there is a mast, increase LV EDP. So that can lead to the pulmonary edema. Complications are fracture or embolization of the device can occur. Device malalignment can occur. Residual shunts can be present. Device thrombosis can be present. Impingement of adjacent structures such as walls, superior vena cava, coronary sinus, pulmonary veins, or aorta can be occurred. Late erosion of atrial or aortic wall can also be possible. At the end of these slides, the certain points need to be emphasized, like specific characteristic of ASD that should be routinely measured and reported, like what type of ASD it is, PFO or primum ASD or secundum ASD, or other atrial communications like sinuses, venosus, or unroofed coronary sinus, anomalous pulmonary venous drainage need to be assessed. A Doppler flow, presence of left to right shunt or right to left shunt or bidirectional flow need to be estimated. Presence or absence of atrial septal aneurysm is also very important, need to be assessed. Associated finding, eustachian walls or Chiari network, if it is present, need to be checked out. ASD size, maximum and minimum diameter, optimally measured from 3D volume, and ASD area that need to be assessed before going for any treatment like surgical or device closure. ASD location in septum, it is a high secundum ASD or sinus venosus defect SVC or IVC type, that also need to be assessed. Measurement of all ribs is very important when you are going for the device therapy, like aortic, right upper pulmonary vein, superior, posterior, inferior, and AV septal. And shape of ASD, round, oval, irregular, presence of multiple fenestration, dynamic nature of ASD, measurement of area and maximum minimal diameter in systole and diastole need to be assessed. Thank you.